Good evening. I hope people can hear me. My name is David Walsh. I'm the Clinical Director of South Australian Perioperative Mortality Audit, and I'm really pleased to welcome you all tonight to our second webinar of the year. In this occasion, we're co-hosting with the Tasmanian Surgical Audit, and we're lucky enough to have presenters from both Tasmania and South Australia. Just a couple of thank yous before we introduce our speakers. The first is I'd like to do an acknowledgement of country and to acknowledge the traditional owners of all the places that we're meeting from tonight, which is quite a few. And we would, on behalf of the College of Surgeons, like to acknowledge their leaders, past, present, and future. I also want to thank the TASM and SAASM staff for pulling off tonight's event and making things work and getting the emails and the links to the correct people, including me. I'd like to thank all of you for taking some time out. We've got a very pleasing number of registrants tonight who we'll see click on and off. There will be a recording of this and the presentations that will end up on YouTube if people are interested in revising it or referring to friends. And I'm very grateful that Jessie I and Richard Turner have made themselves available for tonight's presentation. Tonight we're going to talk about the issues of non-technical competencies and essentially communication. And our first presentation is going to be by Professor Richard Turner, who's going to talk about rudeness as a risk factor in surgical care. Richard is the Professor of Surgery at the University of Tasmania, and he's also a consultant general surgeon at the Royal Hobart Hospital. So I'd like to hand over the presentation to Richard, and hopefully his slides will appear shortly. Thanks,
Sorry,
Richard.
David, I don't mean to interrupt, but two people in the chat have said that they can't hear anything.
Your mic has been disabled.
Okay, someone said they can hear fine, so I think let's continue.
Okay, can you guys hear me?
Yeah, I can hear you. Can you hear me?
Yeah.
Good.
I think it might be a local factor.
I'm seeing some thumbs up, which I'm taking as being okay. So, Richard, the floor is yours.
Thanks very much, David. It's great to be invited to this event. What I'm going to be doing this evening is giving you, I guess, a potted version of the Operating with Respect face-to-face course that many of you may have done, and certainly all of you probably would have done if you with the College of Surgeons, the online version. And what I'll be focusing on is what we would call unacceptable behaviours. You're probably familiar with this iconic video with the Robert character and the Olivia character and the Alice character and so on, that sort of like comes to a climax when he says to the registrar, "You are completely hopeless," making this sort of bald, generalising, personalised comment. That, I suppose, could be considered rudeness. It's probably downright harassment. But in the end, I think a lot of it is really a spectrum of what we would call unacceptable behaviours. Now, I think we'd realise that in our workplace, most behaviours are acceptable in this so-called green zone of the spectrum. And unacceptable behaviours are something worse than that, if you like, but they're certainly not in the egregious criminal category. So in order to prevent them or attenuate them or mitigate them, it requires some sort of informal intervention. It certainly doesn't require invoking HR or people and culture or certainly the forces of the law, but it's something we can all do ourselves in the workplace. Rudeness is known probably in academic circles as incivility. it's basically defined as a low-intensity negative interaction with ambiguous or unclear intent to harm. I think it's really about the perception, not necessarily the intent of the comment. It would be drawing a long bow to say that the Robert character probably really intended for Olivia to learn from this adverse occurrence, but it certainly didn't come out that way. It came across as actually causing harm. But it's not egregious, and it doesn't represent a breach of most, but it does represent a breach of most of the non-technical competencies that RACS prescribes. And this in turn adversely impacts the delivery and outcome of the so-called technical ones. So just to remind you, there's now 10 RACS competencies, and only 2 of those, namely medical expertise and technical expertise, are really clinical or technical. All the rest relate to what could be better termed as soft skills, but these are actually very important because they all impact patient care. So we've got things like judgment and clinical decision-making, professionalism, health advocacy, communication, collaboration and teamwork, leadership and management, scholarship and teaching, and cultural competence and cultural safety. So I think that examples of the behaviour that we see in the video probably breach all of those things. And in the end, it has an adverse effect on patient care. So there is a fair bit of evidence. Sorry, that slide didn't come out the way I wanted. But basically, unacceptable behaviours degrade performance, including in the operating theatre. They reduce situational awareness and undermine patient safety, discourage speaking up about patient safety concerns. So I think we're all familiar with being in a situation with an intimidating boss or someone like that, and and we don't want to break bad news to them about patients and things. And so it actually means that the patient suffers as a result of that because we're afraid to speak up. And obviously this increases adverse surgical outcomes. But also it erodes team resilience, it risks burnout, and it's certainly not good for the scholarship and learning of our trainees and ourselves. Sometimes negative role models can be useful, but in general, in small doses and with a lot of disclaimers. So I think really it's not a good model for future behaviour. I think people would all agree that we can no longer say if it was good enough for me, it's good enough for my trainees or the rest of the team. And the bottom line is that there will be patient complaints and risk of litigation. We have a lot of evidence to say that, that attest to that. This is a single study about 10 years ago, a single centre study from about 10 years ago from the US, where 66 surgeons were involved and over 10,000 procedures. And what's interesting about this is that the solid red line there basically represents high-risk procedures or high-risk patients. The faint dotted line is the low-risk patients or procedures. And we can see on the x-axis the number of complaints made by patients about the surgeons. And as the number of complaints received by surgeons increases, so does the risk of wound occurrences or basically wound infections. That's just one example. They did look at other outcomes with that, including urine infections, chest infections, and so on. But in the end, it was the wound occurrences that reached statistical significance. So we can see that as surgeons had complaints made about them, so did their rate of wound infections. And bear in mind that these complaints weren't related to those particular wound occurrences per se. It was all about what preceded those. So we can see that, I guess, a smoke signal here of the fact that there must be something happening in the team as a whole because of a particular surgeon's behaviour that would lead to lapses in best practice management, perhaps. We've also got other evidence from, once again, also from the US, this time a multi-centre study with over 32,000 patients. This was based on NESQIP data, which is a very robust database. The number of complaints received, and these were complaints about professional behaviour, not necessarily to do with patients or patient complaints, but the number of complaints made about surgeons by their teams or colleagues also predicted the rates of complications. So we can see that almost 14% higher complications for surgeons who had in the highest quartile of complaints. Death wasn't significant, fortunately, but other things like any surgical complication, medical complications, reoperation, readmission, or any of the above. So these were things that really mean that that it's the behaviour of a surgeon, a non-technical skill, so-called, that also affects clinical outcomes. So technical skills by themselves don't ensure an optimal surgical outcome, and the bottom line is that unacceptable behaviours are unsafe. What other evidence do we have about incivility, interprofessional incivility, in its impact on teams? Well, this is actually a study that was actually a systematic review. Because the studies were all heterogeneous in their outcomes and their methodologies, it was basically qualitative and quantitative methodologies. They were just pooled as a systematic review. And we had 26,000 or more participants in this from about 7 different countries. I think there was the US predominated, but there was 1 from Australia, 3 from Israel, and also from Iran and Egypt and the UK. And this showed that interprofessional incivility was common among physicians and nurses, and both had psychological and clinical outcomes, resulting in stress, compromise patient safety, quality of care, and medical errors. The junior staff seemed to be affected twice as much as the consultants, with higher rates in radiology, general surgery, neurosurgery, and cardiology. So I think it's clear that just this low level incivility can be associated with adverse events for patients. What about not even being the so-called recipient of the rudeness? There are studies, I'll quote you a couple of experimental studies that show that even just witnessing rudeness as a bystander can also affect performance. This is a study from the US that looked at dental students undertaking a technical exercise in making prostheses or prosthodontics in a preclinical course, and the intervention was the students witnessing incivility displayed by one of the facilitators to a lab assistant, and it was by a number of parameters on performance. The team that the students that actually were exposed to that, as opposed to the control group, which did not receive that, actually scored lower on various technical competencies in doing doing the exercise. There's another really interesting study from Israel that looked at clinical judgment, I suppose, and clinical performance of NICU teams. That there were 24 of them actually, and the intervention in this was the visiting expert was made some disparaging comments about previous teams' performances in this simulation exercise. which was to do with a deteriorating patient with necrotizing enterocolitis. Basically, he bad-mouthed previous teams and said, oh, well, I hope you do better than the ones that I've seen so far. And as a result, the ones that were exposed to that particular incivility or witnessed it actually performed worse in the simulation than those that were in the control group. So I think we've got some interesting experimental evidence to say that incivility actually has an adverse effect on individual and team performance, both as if they're the recipient, but also if they just simply witness that sort of behaviour from clinical leaders. So this leads us to ask ourselves, how can we actually combat incivility in our workplace? Those of you who've done the face-to-face OWR course will know that there are three cogs in this machine, basically, and they all kind of drive each other. We first of all have to build respect, which in turn builds our own resilience. And I'll talk about resilience in a moment. It's not maybe what you think it is. And it also involves speaking up in the face of rude behaviour. So first of all, how do we build respect? Well, I think there's a lot of talk about flattening the hierarchy. I think we should be aware that hierarchy is not a bad thing. We need to have a hierarchy. We need to have reporting lines. We need to know what each person does and who's responsible for what, and maybe where the buck stops. But we can flatten the hierarchy to make it less susceptible to rankism and authoritarianism by doing a number of things. And we can model acceptable behaviour. We can be champions of good behaviour. We can also challenge by speaking up unacceptable behaviours. We can define clear boundaries and expectations. It's really important to invite opinions and concerns and seek a consensus. People so-called lower in the hierarchy, their opinions should be just as valued as anyone at the top of the hierarchy. Permit others to speak up, regardless of their discipline or their place in the hierarchy. Listening to what they have to say, entrusting, and abide by the rules, protocols, and norms. So, resilience does not mean toughening up. It actually is something a little bit different. It's about us being able to recognise what stresses us and how we can actually deal with that stress response to attenuate it, so that we don't lapse into unacceptable behaviour. Because I think the whole philosophy behind OWR is that we can all be susceptible to displaying an unacceptable behaviour or rudeness in the workplace if we're exposed to stresses. It's basically making sure that your frontal lobe kicks in and you can overcome that flight or flight response. So I think stressors, and I've listed a few there, angry patients, angry colleagues, difficult conversations, a difficult dissection in the operating room, bleeding, time pressure, needing to multitask, all of these things, a busy clinic with complex patients that were added on, a bit like what we saw in the video. These can actually be recognised by a physiological response in a lot of cases. You'd probably realise that maybe your pulse quickens, maybe your mouth gets dry, you start to hyperventilate, you start to sweat. These are all extreme examples of stressors and their symptoms. So if we recognise that and understand ourselves and our bodies and our psyches, we can actually work out ways of slowing down with some sort of low cognitive load activity. So mindful breathing is one example, but even just changing sides of the operating table to get a different perspective on that dissection, to stretch your legs a little bit, handing over to someone else over the operating table. In log operations, you may be able to entrust, which is a good thing for the hierarchy, your trainee to do part of the dissection. And you can take a bit of a break and just take a bit of a breather and just regroup. You can adjust the light. Maybe have a toilet break. In the clinic, sometimes I'll just check my email. Sometimes that leads to more stress, but I think you've got to sort of like time it accordingly. Or review imaging on a ward round, etc. Obviously, these are low cognitive load activities, but they must be appropriate to the context. Maybe a toilet break with a hemorrhaging patient might not be a good idea, but we have to sort of like decide what suits at the time. How can we speak up? Well, I think this is once again a way of flattening a hierarchy, and in the face of rudeness or incivility. And sometimes the first thing to do with speaking up when we see rudeness is to actually break the circuit and just put a stop to it, as politely and respectfully as one can. So it may be that we just cut the conversation, or say, let's just take a break, what have you. It depends. Either way, in the face of extreme incivility that is perceived badly, some sort of cup of coffee conversation, as we call it in OWR, may be indicated. And this should be fairly close to the event, so that it's fresh in everyone's minds as to what was going on and what our perceptions were. And this has various formats. There is a certain advocacy inquiry format that is taught in OWR, but basically it's meant to be non-judgmental conversation amongst colleagues. It's collegial, and it's meant to raise awareness. We don't expect necessarily for someone to say, oh my God, yes, I was in the wrong. That was a really terrible thing to say. If that happens, that's great, especially if it's sincere. But all we want to do is raise awareness about it, so the person will then go off and reflect in due course. And really it's found that people that have received these cups of coffee, once again from the Vanderbilt Institute in the US, have found that more than 70% of those do not have any further complaints made about them in the following 1 to 2 years after such an awareness-raising conversation, even if at the time they didn't actually admit that they saw any problem with what they'd said or did. Something else that I think really is important for us as trainers and supervisors is not to have our feedback, hopefully constructive, construed as incivility or rudeness or harassment. And I think that's, and I see this with a lot of medical students that I'm dealing with as well, that maybe haven't really been given appropriate protocols for feedback, and they're not really aware of what feedback is. It's not always meant to be good feedback. If it means that if it's about how could you do something better, I think we need to make everyone on the same page in terms of what those protocols are, so they know that this is feedback and it's not some sort of personal attack. There are various formats for that, and I think it's important that we actually manage expectations around feedback in our professional lives. That didn't come up very well, I'm afraid, in the PowerPoint, but there's one called the Aloba Principles, and there's also Pendleton's Rules, which a lot of people may be familiar with. But basically, it involves asking the recipient of the feedback to reflect about their performance and what they expect from the feedback, and what they want to do better as a result. So I think it's important to involve our trainees to be part of that feedback process and to actually realise that it is meant to be a gift. But we also need to be able to deliver it properly in a way that's actually non-judgmental by mutual agreement. So I'll finish there, and I guess we can take any discussions or comments at the end, perhaps. Thank you very much.
Thank you very much, Richard. I think we probably might take some questions or some feedback at the end. But thank you very much for your talk and for a nice summary of the issue of rudeness or incivility, which is a great word. Our second speaker tonight is Jessie I. Jessie's going to talk on the impact of non-technical skills in surgical patient mortality. Jessie is a PhD candidate at University of Adelaide, and he's also in recent weeks completed his final year of medicine at University of Adelaide, and he'll be starting work as a PGY1 intern in January. So he's certainly had a busy couple of years. So Jessie, thanks for joining us tonight. The floor is yours.
Beautiful. Thank you very much. Can you all hear me all right?
I think so, yeah.
Okay, very good. Look, I first just wanted to start by saying that it is a genuine privilege to have the opportunity to speak here tonight in this forum and with this audience, and I'm genuinely grateful for the opportunity to share the findings of our research. So this evening I'll be talking about the impact of non-technical skills on surgical patient mortality in Australia. So non-technical skills, or NTS, refers to the interpersonal and cognitive components of surgical professionalism. This includes communication and teamwork, situational awareness, decision-making, and leadership. Now, in this presentation and through all of the research that I've been involved with, we use the term non-technical skills rather than the more contemporaneous RACS professional skills, and I just wanted to take a moment to explain why that is. So the non-technical skill taxonomy and vernacular that we use is derived from several decades of interprofessional and even inter-industry research, including aviation industry, nuclear power, and of course medicine. And that's really valuable because it means by continuing to try to use that terminology, we can then compare between studies, and the lesson learnt from other high risk, high reliability organizations can also be adopted within our own profession. That being said, even more importantly than that, non-technical skills are not separate from the RACS professional skills, as Professor Turner rightly said. In fact, some of them are directly comparable. The way that we think of the non-technical skills is really as the underlying core components of perhaps more complex competencies. For example, if we think about scholarship and teaching specifically, for a teacher to be effective, they surely must have an appropriate level of situational awareness. They must know who their student is. They must understand what the goals of the student are. They certainly have to be able to communicate with that student in an appropriate way and both give and receive feedback. And they need to decide appropriate times or circumstances to teach. So the big question is, how important are non-technical skills? Now, studies have shown that most adverse events in surgery are not caused by failures of technical competency, but they are in fact caused by failures of non-technical skills or non-technical errors. And anecdotally, most of us would agree with that. But interestingly, there's really few studies that have been able to quantify just how important they are. And the studies that have small, non-representative cohorts. Two seminal studies in this space. One included 444 medical malpractice suits that were closed. This was in America. And another included 146 surgical incidents that were recalled by surgeons about 12 months later that may or may not have been involved in the surgical care at all. We do have other studies from Australia, but again, either small numbers or, though there was a larger study looking at inter-hospital transfers, most of the studies use non-standardized assessment methodology. So some of them review the EMR documentations raw. Others use surgeon interviews with semi-structured interviews or completely non-structured interviews, and others use retrospective database audit. Another point is that most of the studies assess only for singular non-technical skill domains. So they might be specifically looking for communication errors, but they don't look across the entire spectrum of non-technical skill domains. Similarly, they are heterogeneous in the nomenclature of non-technical skills used in many of the medical non-technical skill quantifiable studies. So what this means is other than anecdotal and a broad scope, knowing it's important, we really didn't have a good quantitative understanding of just how much harm was being done through non-technical errors. And that brought us to question one: how important are non-technical skills for surgeon-patient in Australia? Before we could answer that question, though, we need to understand how non-technical skills are assessed. So in the literature, as of the start of this year, there was more than 70 published non-technical skill assessment tools. We're able to assess non-technical skills in a myriad of contexts, so pre-operatively, intraoperatively, simulation, ward rounds, you name it, we can do it. But again, much like the previous studies, most of the tools have a different number and type of non-technical skill domains that they're searching for. Interestingly, none of them assess for non-technical skills directly linked to morbidity, mortality, or in fact, any patient outcomes. Something that I think is remarkable is that all of the 70 plus published tools are observational in design. And what that means is that an assessor must observe the surgeon and patient, or the surgeon and team interacting in real time or through viewing recordings. Now, to get an expert assessor in the same place as a senior, very busy surgeon while they're engaging in real world interactions and not then being impacted by the Hawthorne effect is very difficult. And it's made non-technical skill assessment both financially and logistically prohibitive. Because of this, there really isn't any widespread non-technical skill assessment occurring, certainly not in Australia. Also of note is that all current assessment methodologies have a single point-in-time assessment process, which means they really don't capture the downstream consequences. And I want you to think about that for a minute. If we're assessing someone's situational awareness, and a big part of situational awareness is the ability to collect information, understand what that information means for the patient in front of them, and then predict how that information may impact the patient down the line, it's very unlikely that we're going to be able to give a reliable assessment when we just look at them within one simulation, unless it's a scripted simulation, and it's very, very unlikely that we'll get a good assessment of that in the real world. And finally, all of the 70 tools use Likert scale scoring. And I've spent innumerable hours looking at the data, the tools, and even doing some assessment. And for the life of me, I cannot figure out what the difference between a 5 out of 10 decision-making and a 6 out of 10 decision-making clinically means. So really, we have two questions. How important are non-technical skills for surgical patient safety in Australia? And how can we make non-technical skill assessment scalable, standardized, and relevant to patient-centered outcomes? Now, in reality, before we can answer question one, we need to answer question two, and that's what we set out to do. So in our first study, we aimed to develop the system for identification and categorization of non-technical errors in surgical settings, or the SICKNESS. We aimed to validate the novel components of this tool, and we wanted to demonstrate acceptable inter-rater reliability. So we took on a multimodal iterative design. The tool was developed through systematic literature review and modified Delphi process with 6 non-technical skill assessment experts. And then we wanted to pilot the tool, or version 1 of the tool, against 12 months of mortality data to see if we could retrospectively identify non-technical errors leading to harm. Thereafter, we wanted to refine the tool. And the reason we wanted to do this, the whole purpose, in our mind, it wasn't enough to be able to identify an error. We wanted to see how granular could we get. Can we actually identify the behavior that has led to patient harm, the non-technical skill domain that was failing? After tool refinement, we would then pilot the tool again against a different 12 months of mortality data. So here's version 1 of the SICKNESS. It's really quite simple. On the left side, you can see the 4 non-technical skill domains. And on the right side, under each domain, you can see a sub-element. This is making up the components that really encapsulate each one of those domains. We replaced Likert scoring with binary scoring. There either was an error or there wasn't. Using version 1 of the tool, we audited 12 months of mortality data from ANZASM. Specifically, this was 2012. And I'm sure everyone in the room knows what it is, but I'm just going to very quickly run through it. I think we're incredibly fortunate that here in Australia we have ANZASM, and that every surgical mortality is mandatorily reported to ANZASM, except New South Wales, which is reported to CALHN. What happens then is the surgeon who is involved with patient care is sent a standardized report form, so they have the opportunity to outline the components of care leading up to patient demise, and they can reflect on areas that either they would have done differently or they would hope to improve in the future. This is then de-identified and sent to a first-line assessor, which is a consultant surgeon of the same specialty, The purpose of this assessment is to try to identify, are there any clinical management issues? Is there anything that could be improved? Is there anything that was directly related to patient harm? If there's sufficient information based on the surgeon form sent, the case can be closed and feedback can be provided to the hospital to try to encourage ongoing improvement and prevent similar occurrences from happening. If there's insufficient information, it's escalated to a second line assessment with another consultant surgeon. And again, trying to identify clinical management issues to provide feedback. So what we did, we took all surgical mortalities with an adverse event or an area of concern in 2012. We then assessed each case using version 1 of the sickness. This was done by 2 independent reviewers. And they were trying to identify, is there a non-technical error linked to death? And if yes, to which non-technical skill domain did it belong? The primary outcome here was reliability of the tool. In the first 12 months that we audited, there was 413 surgical mortality cases. We had strong agreement, strong inter-rater reliability, using the tool to identify if there was a non-technical error linked to death. We then had moderate to strong reliability when the reviewers were trying to categorize them into non-technical skill domains. And we had moderate agreement, what we called overall agreement across the 4 domains. What that actually meant was that the reviewers not only agreed that there was an error, they also agreed in the number of errors and to which domains they all belonged. On to the refinement stage here. Within the 413 cases, there was 285 errors that were identified by both reviewers, which means we had 570 individual error reports. That is, both reviewers wrote a little report on each one to try to characterize what the error was. We conducted a thematic analysis of that to come up with exemplars that was then sent back through our modified Delphi process. And the result was 50 error exemplars. These 50 error exemplars were thought to appropriately encapsulate all of the behavioral errors that we had seen across the 12 months. And this is what version 2 of the tool looked like. So it's a slightly more complex than the first one, but fundamentally very similar. On the left, we have the domain. Next to that, we have the elements of the domain, and then we have the specific exemplars within. So this is for communication teamwork, same for decision-making, situational awareness, and leadership. Whilst we were refining it and going through the results of Pilot 1, we actually noticed that in cases with multiple non-technical errors, there was poorer agreement. This led to the development of a novel mental model, which is the primary versus resultant mental model. And what this means, a primary non-technical error was defined as the first identifiable non-technical error that occurred independently of a preceding non-technical error. Now compare this to a resultant error, which is a non-technical error that occurs because of a preceding non-technical error. And I think the best way to explain that is to walk you through a case. Now this case was taken from the ANZASM audit, though it's been simplified, as I'm sure you'll appreciate, and de-identified, of course. Patient presents to the ED with necrotizing fasciitis. A junior surgical team member is called, comes and inspects, but fails to recognize that it is necrotizing fasciitis, mistaking it for simple cellulitis. Because he or she thinks that it's cellulitis, they then don't emergently communicate with the senior. Doesn't want to wake him in the middle of the night, it can wait till tomorrow. However, because there's a delay in being assessed by a senior surgeon, unfortunately the patient deteriorates, and despite heroic efforts at debridement, patient subsequently dies. In this scenario, there are 2 non-technical errors. The primary non-technical error is the situational awareness error. The first point at which the cognitive landscape have shifted was when the junior surgeon failed to recognize necrotizing fasciitis, the result of which is they do not communicate with their senior. The reason this is pivotally important is so that we can accurately target improvement efforts. If this particular individual was sent to a communication workshop, it's very unlikely it's going to prevent them from not recognizing necrotizing fasciitis in the first place, in future. So it's pivotally important that we address the primary situational awareness error and then can understand how to move forwards from there. So now, armed with the 50 exemplars and with the novel mental model of primary versus resultant, we ran through Pilot 2. This was another 12 months of surgical mortality data, this time of 2019. Same principles, all cases with an adverse event or area of concern over the 12-month period, assessed using the refined sickness by 2 independent reviewers, and they were trying to identify a primary non-technical error linked to death, and if so, then categorize it into domains. In this 12 months period, there was 432 surgical mortality cases that were eligible, and we can see that the inter-rater reliability improved for 5 out of the 6 outcomes. So we now have a tool. The tool has been validated through modified Delphi process with consensus from experts. It's got moderate to strong inter-rater reliability, and it enables the articulation of a primary error, the first point at which cognitive landscape had been shifted. Armed with this, we set out to answer our big question: how important are non-technical skills for surgical patient safety in Australia? In this study, we wanted to quantify the incidence of primary non-technical errors linked to patient death over an 8-year period in all surgical specialties in Australia. We wanted again to categorise those non-technical errors into the non-technical skill domains, and we wanted to investigate change in non-technical error incidence over time as a surrogate marker for historical nationwide improvement efforts. This time we conducted an 8-year retrospective audit from 2012 to 2019 inclusive. Again, using all cases from ANZASM in which there was an adverse event or an area of concern flagged. Each case was assessed again by 2 independent reviewers, but this time if there was any disagreement, it was escalated to a 3rd senior reviewer. And again, we were trying to identify, is there an error linked to death? And if so, what is the domain? Over the 8-year period, there was 30,971 mortality cases reported to ANZASM. Of these, 3,829 cases were flagged as having an adverse event or an area of concern. Unfortunately, 134 needed to be excluded as there was insufficient free text in them to allow the sickness tool to be used appropriately, leaving 3,695 cases to be included for full analysis. Of these, we identified a non-technical error linked to patient death in 64% of the cases. And at the risk of being dramatic, I just want you to sit with that for a moment. If 64% of all cases of mortality with an adverse event or an area of concern had a technical error, there would be riots in the street. Of the cases that had a non-technical error linked to death, 58% of them had a primary decision-making error linked to death. 56% a primary situational awareness error linked to death. 15% communication teamwork error linked to death, and 5% a leadership error linked to death. Next, we wanted to analyse how the incidence had changed over time. So for those of you who are not familiar, this is an SPC chart, or a statistical process chart. And what this chart does is it allows the plotting of data over time, and it measures the variability within a system. Within any system, there is random fluctuations, and they may not be meaningful. However, if those fluctuations fall out of randomness, I suppose, if they, based on some well-defined rules, they are no longer random at all, and they actually represent significant change. So the significant change, or special cause variation as it's known, is noted by the different coloured dots. In orange at the start of this figure, which represents the incidence of overall non-technical errors inclusive of all domains over the 8 years, shows there was an initial worsening in the first 2 years of the audit, and then there was a improvement in the final 2 years of audit. And an analysis of the trend shows there actually was a significant improvement, meaning there was a significant reduction in fatal non-technical errors over the study period. So that's fantastic news. But I want to draw your attention to the last 2 years, from January 2018 to October 2019. Though this was the best period and represents an improvement, you can see all bar one of the quarters was still well above 50%. So still alarmingly high, and there is still work to be done. When we look at it by domain, we can see the communication and teamwork errors over time here. Again, there was an initial worsening followed by a period of improvement, but analysis of the trend here showed that there wasn't any prolonged improvement over time. For leadership errors, again, an initial period of worsening, and then a rather prolonged period of improvement, but analysis of the trend shows the same thing. There was no prolonged improvement over time. Decision-making errors, remembering that these were by far and away the most prevalent fatal error type, there was a period of worsening, but there was no period of improvement whatsoever. And again, analysis of the trend shows that the fatal decision-making errors did not significantly decline over this 8-year period. The same is true for situational awareness errors, with no improvement seen. So, how important are non-technical skills for surgeon patient in Australia? Very. The evidence is quite clear on that. 64% of surgical mortalities with an adverse event or an area of concern had non-technical errors linked to patient death. A primary decision-making or situational awareness error occurred in greater than 50% of all of these mortalities, and there was minimal to no improvement over time. So this is a great starting point. We've now quantified it, and we've identified some national priorities. Decision-making and situational awareness needs to be improved, and that's a fantastic place to start. However, it's a very, very broad target, and we certainly didn't feel confident that just saying all decision-making and situational awareness in all surgeries across the nation needs to be improved. We didn't really think that was going to lead to much impactful change. And the truth is there's far more questions to be asked before we can start to really make a difference, I feel. And one of those is, do different surgical specialties have different non-technical skill challenges and priorities? To paraphrase George Orwell's 1945 cult classic Animal Farm, all surgeons are created equal, but some surgeons are more equal. Now, obviously, I'm being facetious here and a bit tongue-in-cheek, but under the umbrella of the Royal Australasian College of Surgeons, we have cardiothoracics, vascular, neurosurgery, general surgery, which includes HPB, upper GI, breast endocrine, colorectal, and myriad more surgical specialties. Each one of these surgical specialties has unique patient profiles, demographic, they have difference in systems that they're using, perhaps different acceptable intraoperative risks, and many, many other differences. But no one had ever explored how non-technical skill priorities may differ from each surgical specialties, or if it's different at all. Which brings us on to the third and final study that I'll discuss this evening, where we wanted to investigate this difference in the specialties. So aim one was to investigate the incidence and characteristics of fatal non-technical errors by surgical specialty in Australia. We then wanted to compare non-technical error occurrence across specialties to try to identify if there are statistically significant differences between each specialty. And again, we wanted to investigate the change in non-technical errors over time by specialty. Now, we used the same period of data, which again, there was 30,971 deaths. We were able to assess 3,695 of these. And interestingly, approximately 93% of these cases belong to 5 specialties. Now, I want to premise this by saying that this is not meant to be punitive. This is speaking exactly to the point I was making earlier, that there are differences, there are higher risks, there's greater patient numbers, and all those sort of things to take into consideration. What it did mean is a comparative analysis between a specialty that has a high representation in the mortality audits, as opposed to one that has a very, very low, wasn't really going to be meaningful. So we only focused on the 5 most representative specialties. They included general surgery with 1,570 cases with an adverse event or an area of concern, cardiothoracics with 626, orthopedics with 510, vascular with 385, and neurosurgery with 331. At the top of the screen now, you'll see each of those 5 specialties with the denominator of cases underneath. When we assessed the incidence of fatal non-technical errors across them, we found a low of 52% in orthopedics and a high of 69% in general. But notably, there were statistically significant differences between each specialty. For decision-making, there was a low of 53% in orthopedics and a high of 66% in cardiothoracics, and again, statistically significant differences between specialties. Situational awareness, there was a low of 44% in neurosurgery and a high of 63% in general surgery. Again, statistically significant between each specialty. And then for both communication, teamwork, and leadership, there was no statistically significant differences, but there were not significantly, I shouldn't say, there were substantially lower proportions of these types of errors compared to decision-making and situational awareness. Again, we then looked over time. So for overall non-technical errors in general surgery over that 8-year period, we saw an initial period of worsening, much like the previous graphs, and 2 rather prolonged periods of improvement. So in fact, general surgery was the only specialty that showed a significant improvement over the study period. And much like with the first graph, I want to show you the final 2 years are still alarmingly high. So this is, again, as I said, the only one that's improved, but the final quarters, we're still seeing over 50% of all adverse event cases with a fatal non-technical error. For vascular surgery, there was a period of improvement, but no significant improvement over the 8 years. There was no significant improvement in orthopedics, in neurosurgery, or in cardiothoracic surgery. So do different surgical specialties have different NTS challenges and priorities? Absolutely they do. We found statistically significant differences in the incidence and type between the specialties. But despite these differences, the incidence of fatal non-technical errors are universally high, still at 52 to 69%. And irrespective of the specialty, decision-making and situational awareness are still significantly higher than the other non-technical skill domains. and minimal to no significant change over time. So what is the conclusion? Non-technical skills errors and non-technical skills contribute substantially to surgical patient mortality in Australia. And we've seen little to no improvement over the 8 years that we're studying this, which was 2012 to just before COVID hit. But I don't want this to all be doom and gloom, and obviously this is a serious topic and one that I'm very pleased we've had the opportunity to start getting some numbers behind. But I feel very optimistic, and I'm sure my research group does too. Moving forwards, I don't want to lecture, but there are certainly opportunities. And the first is in non-technical error assessment. Again, we now have a tool that enables standardized, validated assessment of non-technical errors in a retrospective fashion. And assessment can occur quite simply, inexpensively, because the tool is freely available online. And I think it should occur, even I hope to see it occur in two different ways. The first is at a national level. Using the ANZASM database, which is a profoundly important database, we can start to see national trends, and that can certainly help to understand the big picture problems and maybe direct some resources. But equally as important, we can start to use the sickness tool at a local level. We know that clinical audit and M&M happens ubiquitously in surgery, and using the sickness as a clinical adjunct to that would be a seamless maneuver that would then give local information about what was going on within a unit, within a hospital, within a state. And in doing so, then more local initiatives can be instigated. We also need further research, and I'm proud to say that we're continuing along this path. We're now starting to look at populations that are overrepresented in the mortality data, such as hip fractures in orthopedics or emergency surgery in general surgery. So again, we can continue to get more and more granular. We can start to identify what are the specific behaviors that are occurring again and again and again, yet not to be punitive, but so we can start to mobilize resources and try to improve these in the future. And finally, we need to instigate some non-technical skill improvement initiatives. We conducted a systematic review and meta-analysis that was published early this year looking at all non-technical skill improvement initiatives, and there is evidence to say that it can be improved. We know that to a certain degree, didactic workshop education works, simulation works, this concept of practice with quality debrief works, and coaching has been shown as an effective intervention to improve non-technical skill errors as well. So I hope to leave you here this evening with a little bit of a fire under your belly. This is something that we quantitatively know is important, but we have some tools and we have some opportunities to try to improve this scenario here in Australia and offer patients best possible care. Thank you very much for the opportunity, and I must thank my team and all the people who have helped me along the way. Thank you.
Thank you very much, Jesse. That's a really interesting work, and I know you looked at adverse events and concerns only from the ANZASM database, but of course there's also a wide and broad number of considerations, which I'm sure would be just as interesting. I'm going to, there's sort of a few things happening in the chat, so I'm going to try and pull out a couple of things, and I apologize if I miss something, but there's a question about whether there's a difference between male and female surgeons, or any evidence of a difference that you know of from your work or the literature, Jesse.
Yeah, that's an interesting question. From the ANZASM work, I can't speak to that because everything was de-identified. So, you know, we had optimistically hoped that maybe we would be able to discern, you know, sex of the practitioner. You can discern sex of the patient at most of them, but no, I can't directly speak to that, unfortunately. But again, by getting more information, especially at a local level, that's something that we can then start to better understand.
Okay. There's another question asking about whether the specific domains were looked at on a specialty basis, and whether that was drilled down any further, Jesse.
So no, the domains were not. The 4 domains that we've included, the way that we reached those 4 domains, again, we used the modified Delphi consensus, but what we did is through the systematic literature review, we took every single domain that had ever been reported, that had ever been assessed. And the interesting thing we found in that is almost all of the domains in the literature had no explanation whatsoever of what the underlying concept was. They were domains in title only. An example of that is cooperation and coordination versus communication and teamwork. I'm not sure what the difference is. They have not been articulated. So we were just left with this absolute nest of domain terminology, and then it was on us to try to dig through and figure out what the core concepts were. So no. However, I think what would be more valuable is to focus on the exemplars. So if I speak to the study that we're doing on orthopedic hip fracture, not only are we reporting the domains like we have in these studies presented tonight, and the elements, but we're also starting to collate the number of specific behavior exemplars. And we're seeing some really interesting patterns. So the reason we feel that is so important is that, you know, to some degree, the concept of situational awareness is still a little bit ethereal. Whereas when we're getting down and looking at the specific behaviours that were observed, and there is a report that led to harm, we really think that's where the money is. But again, at the risk of repeating myself, if we start to get more local level data or more buy-in from some other people that want to help look at that, then absolutely, I think that's invaluable.
Richard, are you still there? I want to ask put a question from the chat to you. Richard, do we know anything about what happens for those that attend the OWR courses? Do we have any research or a feel for any change that's occurred from the introduction of that course? I think
he was gesturing that he may not be able to hear you.
Okay. Not quite sure what's happening. Others hear me at the moment? Just you and me, Jesse. Yep, the thumbs up.
There's thumbs up.
Not sure what's happening. Richard, Richard, you're still muted. No, can't hear. Okay. You'll have to unmute him. Not sure what's going on. Jesse, there is a question about whether there was any evidence or data from public or private patients from your study. I guess that may not be there.
Actually, it is. That's another really interesting question. So something that I didn't go into this evening, but in all of our studies, we also conducted multivariable logistic regressions to look at what variables we could identify. So this included private versus public. It included male versus female versus other patient sex. It involved the age of the patient, emergency versus elective, myriad other things. And in fact, we did find, and when we were looking at all specialties grouped together, that there was no differences. But when we started to look at specialty specific, we saw private versus public, for example, there was a significantly higher odds ratio of having a fatal non-technical error if you were treated electively versus emergency. And if you were treated, now I don't want to get this wrong because I may vary, but I think it was privately versus public. Now, that invoked a real fire with us and something that we're now exploring quite in depth, and speaks to the fact that each specialty does have nuanced situations. So again, if we talk about hip fractures in orthopedics, for example, we know that there is a large amount of them that are done emergently. There is a large amount of them that are done palliatively as well. And how does this influence things? So it would be a little bit premature for me to say exactly what that means. But we know that it's significant. We know that these variables need to be explored in greater detail. We need to get more granular so that we can start to really direct our resources and prevent these things from happening in the future.
Richard, are you back online?
Yeah, I'm back now. It was just my speaker thing. Yep. So I think that there was that original survey that everyone did back when OWR was instigated, which showed a fairly significant rate of people experiencing DBSH. A subsequent repeat survey was done a few years ago, and that showed that there had been some improvement, but it was still quite prevalent. I think we've still got a bit more work to do. And having said that, I think a lot of people now are familiar with all the catchphrases from OWR, so that you can almost sort of like, just say amber moment and everyone's kind of like, on the lookout then to try and mitigate any stressors. So I think it is sort of working, but I think we need some more hard evidence to say that.
Jesse, there's a question about whether the non-technical errors that occur in surgery equate with the cause of death, or are they do you have any data about the link between causing a death, which we identify in ANZASM, or not contributing to a death?
So if I've understood the question directly, is this perhaps a question about how we qualified a non-technical error as being a fatal non-technical error rather than just okay? So it's a great question. I think it's an important question, and I want to give you an example. Patient dies because they've aspirated, right? And this is because they had a small bowel obstruction. So a lot of the diagnostic auditing protocols would say, well, the adverse event was that there was an aspiration event. That's what led to death. We should definitely learn about avoiding aspiration and what have you. And in innumerable cases, specifically relating to general surgery, but the lesson is applicable across. What you would find is there was clear evidence of an undiagnosed small bowel obstruction 12, 24, 36 hours before the aspiration event, which means there was a situational awareness error. Someone failed to recognize the patient had a small bowel obstruction. Because of that primary error, they then failed to put in an NGT, which would be a resultant error. And because they failed to put in an NGT, eventually the patient aspirated and died. So by only focusing on the diagnosis of aspiration, or I suppose diagnosis categorization of it, we miss so much of what can be prevented or what's really happening. So we certainly considered what the cause of death was, and then we would work back to try to find what the first identifiable non-technical error was that, again, shifted the cognitive landscape.
All right, and I think the final question was again to Richard's, coming from our chat. The question is, what is the number of surgeons, I guess percentage of surgeons that have attended the WR course, and how can we engage with the non-attendees?
I just typed it into the chat. I think it's a resourcing issue, really. We'd like to run more courses, but it's all about money and facilitators and things. But at the moment, it's really just offered to people in who are supervisors of training or in leadership positions. Occasionally, people self-refer, and that's really good. But yeah, we'd like to run more courses if we could.
Yeah. All right. Well, I think we've sort of drifted sort of to past 7 o'clock. I mean, I think one of the things about that I'm often talking about the ANZASM audit is that the lessons about what happens to our patients. We talk about the ones that have died, but there's also another group that get complications, or a prolonged hospital stay, or a very bad experience for staff or patients. So I think the lessons that Jesse and Richard are talking about are having impact on our patients, even if we consider that the ones that die are the extreme. It's behaviours and problems that are leading to problems across our health system, and I think we need to think very broadly about this data, and it's really nice to see the stuff that we do in putting these cases into ANZASM, and the work that the fellowship does in supporting it, showing us something about how we can move forward with it. So I thank Jesse and I thank Richard for their time tonight. I might again thank all of our people who've attended tonight. We have a regular program through ANZASM of the various states, working throughout the year. This will be our last SAASM one, and we'll come up probably, as will Tasmania, again early next year. So I would invite you all to stay, keep an eye on the programs and your emails. And I'll thank everybody that's been involved tonight, and we might thank you for your time, and I'll see you all later. Have a great rest of your evening. Thanks very much.